Good evening, good morning, or good afternoon, wherever you are in the world, as we have around 1,000 attendees joining from all around the globe. My name is Petra Labs, and I am the Clinical Market Manager of Women's Healthcare in Europe. On behalf of Canon, I'd like to welcome you to our Women's Healthcare webinar on ultrasound and multiple pregnancies. And a special welcome to our three highly skilled speakers, Professor Asma Khalil, Professor Franz Baumann, and Dr. Monique Haag, who are going to share their expertise on multiple pregnancies with you. It's my pleasure to introduce you to Professor Asma Khalil, our moderator and speaker for tonight. She's a professor of obstetrics and maternal fetal medicine at St. George's Hospital, London, and the director of the fetal medicine unit at Liverpool Women's Hospital. She's a real maternal fetal medicine specialist and is 100% committed to the implementation of clinical guidance, guidelines, and practice. She played a major role for developing, updating the ISUG, the FIGO, and NICE guidelines on the role of ultrasound in twins and multiples. With several hundred publications, she is one of the leading ultrasound experts in the world. Please, Professor Khalil, it's your turn to start now.
Hello, everyone. As Petra mentioned, good morning, good afternoon, good evening, depending on where you are. Thank you, Petra, for the introduction, and thank you for organizing this webinar. Webinars on ultrasound and multiple pregnancy, an area which I think is extremely important. Twins and multiple pregnancies are associated with increased risk of perinatal mortality and morbidity. They also sometimes can be challenging for prenatal diagnosis or fetal therapy. Today we have a really fantastic program with excellent speakers. The program will be approximately 1.5 hours. This webinar will focus on the new evidence and the new guidance in twins and multiple pregnancy. I'm going to introduce the first speaker, Professor Frank Baumann, who is a chief physician, and he is leading the prenatal diagnosis and also fetal surgeon. And he's got extensive experience in managing twin and multiple pregnancy, particularly the complex cases. And he's going to talk to us about early prediction of complications in twin pregnancies. Thank you, Frank.
So thank you very much for the introduction, Asma. My aim is that I would like to give an overview about the early ultrasound in twins to predict pregnancy outcomes. And this is a very interesting part because the first trimester screening, also in multiple pregnancies, are very important for counseling pregnant women and also for the management in the further pregnancy. And the most important thing in the beginning of the pregnancy is the determination of the placentation, of chorionicity, and also of amnionicity. And we can do this also in very early age of gestation. In these pictures you can see here at 7 weeks the dividing interfetal membranes with very thick membranes that was typical for dichorionic twins. And on the other hand, in this early age of gestation, we can see no dividing membranes. So this is typical for a monochorionic twin constellation. So what is important for the antenatal care in first trimester? The first step is determination of the type of placentation, as I pulled out before, with chorionicity and amnionicity. Then the accurate dating of the pregnancy with crown rump lengths, because we have to look for the intertwin discordance, because in this condition, the problems are much more higher than in normal growth of the babies. And for measuring the crown rump lengths, we should measure the larger twin. That was the recommendation from the ISUG for using the gestational age. Then the next step is screening for chromosomal and structural abnormalities with the first trimester scan between 11 and 13 weeks, especially with nuchal translucency, but also for looking to rule out heart defects or structural defects of the fetus. And we can combine this with the NIPDS or the C3 DNA. We have to look very careful for the monochorionic twins, because these twins have higher problems in the further pregnancy. So this is the first step. And we can see that in this publication, the lambda sign in the first trimester was published first in 1981, and this early for 40 years ago. And in this age, we can see have a sensitivity of 97%, and with the new ultrasound techniques and equipments, we can reach a sensitivity from more than 99% to detect the lambda sign. In this image, you can see this typical area, and this was typical for dichorionic diamniotic twins. And this make an amount of around about 80% of all twins. And on the other hand, we can look for the T sign. That was a very small inter-twin membrane layer. And this is typical in the fusion in the monochorionic twins. And we can see it in 20% of twins. And we couldn't see the intermembrane or the inter-twin membrane, then there is in 1% of the twins, the monoamniotic situation. We can see this also in triplets, because in this images you can look or you can see at once the monochorionic twins, and the other twin that was divided by the thicker membranes. So you have both areas and both parameters where you can decide the chorionicity and the amnionicity. The Bayer have in 1997 shows this by a systematic first trimester screening that monochorionic twin shows a 6 times higher fetal loss rate and also a 2 times higher perinatal rate compared to dichorionic twins. And to date, it is suggested that the high rate of early mortality in monochorionic twins is a consequence of arteriovenous vessels and the development for TTTS. The problem is that there was some hemodynamic imbalance, and that causes some problems with the blood pressure within the fetus, and also some changes by angiotensin levels, and also some changes with polycythemia, hyperviscasia, and can make also some steal effects. And this changes in the blood pressure makes morbidity especially in the fetal brain. So it's important to look for more monochorionic twins for the amnionicity. And if you can look for the dynamic process during the early stage of pregnancy, the amniotic membranes are fused by increasing the gestational age. So in early age of gestational age, you can detect very clearly the amnionicity. So that is very important to look with transvaginal ultrasound or with abdominal ultrasound for the evaluation of these membranes. The complications could be typical, that would be answered in the next lectures. And therefore, there's also a lot of risk with intrauterine death, and if the surviving baby has also some problems with neurological deficits. So that's important to detect it very early, that's the problems. So therefore, there's the idea of Nikolaides that was published for 10 years more. And he has introduced first trimester screening and rule out a lot of chromosomal abnormalities, also congenital malformations. And typical part is also the multiple pregnancies. And the idea of this is to look very early in pregnancy to improve and optimize the perinatal management and also the counseling of the parents. So that makes a clear management for the parents. There was a very good publication published by Litwinska. That was a retrospective analysis of prospectively collected twin data in the last 10 years with no major abnormalities. So they are very healthy. And they show that the overall survival rate in dichorionic twin was near 98%. Monochorionic diamniotic twins has a survival rate of 92%, and the monochorionic monoamniotic of around about 78%. But we see that the monochorionic twins have also a higher fetal loss rate before 24 weeks, also for one and also for both fetus, and also the risk of perinatal death after 24 weeks is increased in monochorionic twins. We have also the problem of preterm birth below 32 weeks. So the incidence is higher in monochorionic twins, also for small for gestational age fetuses. And the gestational age in the monochorionic twins are significantly lower than compared to dichorionic twins. And the monochorionic twins have around about 10% risk of TTTS and or selective fetal growth restriction. So what is the idea to look also for the pregnancy outcome? And this group of round of Litwinska shows that the intertwin discordance have also an influence on the pregnancy outcome. And they can show that the discordance of the chromosome rump length is more than 10% or more than 20%, then the risk is increasing for fetal loss rate. And the incidence is for dichorionic twins is around about 8%, but it's significantly higher in monochorionic twins. So conclusion of this publication was that increased chromosome rump length discordance in dichorionic and monochorionic twins is associated with increased risk of fetal and perinatal death, preterm birth, small for gestational age, and birth weight discordance more than 20%, and in monochorionic for TTTS. But the intertwin discordance is not a good predictive marker, so it's for given the outcome and for an adverse outcome, so this prediction is poor. So the next step is that look for the increased nuchal translucency at 11 in the first trimester, and the incidence was for dichorionic around about 8%, and with monochorionic in 10%. It was significant, but there was no difference between the monoamniotic twins. So the monochorionic diamniotic twins, the overall rate of fetal loss or need of laser surgery was around about 10% below the 20 weeks. But in monochorionic twins, if the nuchal translucency is higher than 95th percentile, the rate is increased by 25%, so it's doubling. And so survival in monochorionic twins also with increased nuchal translucency is lower, but the survival after 20 weeks is not significantly different. Also, in this case, the performance of screening tests by fetal nuchal translucency as a predictor of fetal loss or TTTS is very low. Another publication was that that shows that discordance in nuclear translucencies could also be a prediction of twin-twin transfusion syndrome. That was published by Oliver Kagan, and he found also 11% of TTTS. So this is a number of the risk in monochorionic twins, and he shows that nuclear translucency discordance from more than 20%. That was found in 25% of all investigated cases. And of these pregnancies, 30%, 1/3 developed in intrauterine death or in twin-twin transfusion syndrome. So for all, it's very good to look again for the nuclear translucency and the technique of measurements. It's important to have a magnification and reducing the gain, because then you can detect also the most important structures like nuclear translucency. You can see also the nasal bone and the intracranial organs to detect perhaps in spina bifida. But the most important thing is that we make a very good measurement, an accurate measurement of the thickness of the nuclear translucency, and measure the largest distance by an inner measurement. The other idea is that we have perhaps a possibility with the new techniques of ultrasound to check the hemodynamics of the fetus, and that we can do with the ductus venosus, because this vessel, the flow of this vessel can present the pressure within the right atrium, and therefore can look for an imbalance and also for a dysfunction of the heart. And in this publication, the aim was to predict a twin-twin transfusion syndrome, but this is possible. We can do when the flow during the atrium contraction, the A wave, then the risk is increasing by an alteration of around about 11, but the sensitivity and specificity is not so high, but it is a marker, so we should be very careful that we see an abnormal blood flow in higher pulsatility of the ductus venosus. And the combination of nuclear translucency discrepancy and also an abnormal flow increase the relative risk of around about 21. And this reflects an early manifestation of this imbalance in twin-twin transfusion syndrome. This is an example for a baby that shows the donor that was a normal nuclear translucency with normal blood flow pattern of the ductus venosus, and the recipient who get all the amount of the amniotic of the blood volume have an increased pulsatility and high right atrium pressure. So the other pregnancy is there was a review and meta-analysis that looks also for the risk of twin pregnancy, and they rule out that reversed A wave in ductus venosus have also a high prediction rate for the risk of twin transfusion syndrome, also together with nuclear translucency discordance from more than 20% or more than 0.6 millimeters. The other point is not only for monochorionic twins to look for fetal defects, and this is also a very important thing. And this publication that was by Zingelacki, published in the White Journal, shows that the fetal nuclear translucency more than 25 percentile and or a higher increased nuclear translucency without chromosomal abnormalities have a higher risk of fetal defects. And in this study, they show that in 1/3 of all malformations, this was detected, but in monochorionic twins, the detection rate was higher. And that was the detection rate of the malformations are comparable to the singletons. And in this study, they show that in 100% encephalocele, holoprosencephaly or acrania, omphalocele, gastroschisis, conjoined twin, and so on can be detected in 100%. And also other malformation can be detected very clearly, but not in this age, in this range. So this is important that also in discordance of the crown ranculums, more than 10 or 15%, and also an increased nuchal translucency are associated with fetal artifacts. Now there are some examples for this normal anatomy of the abdomen, also in a very early age of gestation. We see the body stalk anomaly, gastroschisis in this area, and also the omphalocele that can be detected very clearly in this first trimester screening. Also with the head, we can see the acrania or anencephaly, and the alveolar holoprosencephaly and the encephalocele in this area. This was typical, and the plexus choroideus in both sides can be, if we detect this in this early age of gestation, so we can rule out all this fetal malformations of the fetal head. So that's a very good thing. The normal anatomy can be also detected very clearly, and we can detect congenital diaphragmatic hernia around about in 50%, and also the megacystis, like that was a cause of luto, that was detected around about in 70%. Also, the urogenital system is possible to detect with the kidneys and with the vessels, but also with dysplastic kidneys, we can detect it very early. And also in some cases, there are some irregular structures of the parenchyma. So that could be a sign of polycystic kidney diseases. The heart is also one part in the new or in the new technologies. It's possible that this small area that was around about 6.5 millimeters, we can clearly divide the left and right ventricle. We can take the ADF flow with a very clear inflow within the ventricles, and with the ISM-I flow, it's more accurate to have a very good flow of this part. So therefore, it's also possible to detect heart defects, like in AV channel, or in this case in heterotaxia syndrome with cardiomegaly, or with tricuspid insufficiency. That was also a sign that we have to look very clearly if we have an increased nuchal translucency. Then the conjoined twins is also in typical malformations that we can see very early at 11, 12 weeks, where we have an thoracoabdominophagus. And so in 100%, the detection rate was in the first trimester scan. So it makes sense this, to make this early diagnosis. And if we compare it with the scans in singletons, we find that also we have the same detection rate, around about 40%, and with the same organs that was involved. And that was also another publication that was more than 10 years old, but the detection rate was around about 50%. And we can increase the detection rate if we combine the transabdominal and transvaginal ultrasound. So the last part is the TRAP sequence. This is a very severe problem in monochorionic twins. There was one baby that was looks nice and fine. That was a pump twin, and there are small vessels, and the pump twin pumps this blood to the other baby that was an acranius acephalus. And so the problem is that there was an injury in very early age of gestation, and there was a malformation of especially from the cranial structures. And also there are some problems within the placental vessels. So there was the pump twin makes hemodynamics also for the cardiac twin. So we have the possibility with 3D also to make some very fascinated images. That is not easy in every case, but it's possible. The most important thing is that we have to think about this problem in monochorionic twins. So it's very clearly to look very in detail the structures of the head, and then we can rule out very sure this very big problem. So there are also some prognostic criteria. That was especially the abdominal size of the cardiac and the pump twin. So there was an ratio, and if the ratio is more than 50%, then the risk for a demise is very high, with preterm birth, also with polyhydramnion, and also with cardiac insufficiency. And that is the reason why there's not a clear advice at this state, but there is some idea that we have to treat this with some special treatment intrauterine. And there's a problem. There are different therapy options, and the most popular in the last years is the intrafetal or intrauterine laser therapy. You can see the cardiac acephalic, the TRAP sequence, and also in 3D. And you take a very small needle and with a laser fiber and with energy and coagulate the cardiac acephalic twin. So the rates are very, very good in this situation, because we do nothing, then the risk of fetal loss is more than 50%. And also the injury is also high. And we have an average by this meta-analysis, we have survival rate around about 80% if we make this operation. I have also a few cases, and so it's a very easy therapy, but the management the constellation of the parents have to be very in detail. So in conclusion, assessment of chorionicity and amnionicity at the routine scan at first trimester is essential for a good constellation on counseling of parents, and also for planning the perinatal management and also the birth. Ultrasound evaluation of the fetus in first trimester can detect more abnormalities and chromosomal abnormalities. And the rates of fetal loss, perinatal deaths, preterm birth, SGA are higher in monochorionic twins compared to dichorionic. The nuchal translucency and the discordance is an effective parameter to predict TTTS and also for malformations. But it's have still very poor positive predictive value, and this was the same in intertwined difference, also with ductus venosus and tricuspid evaluation. This was not predictive for TTTS, so we have not a very good parameter to detect it very early. And the rate of fetal loss can be reduced by fetoscopic laser that was discussed in the next lecture. And I think that early counseling of parents are very important at this first trimester screening, because the emotional situation for twins, parents with twin pregnancy are very confused in sometimes, and that is very important to have a good management. And that is important to have a good birth event and also a good outcome. So thank you very much. This is the aim, that all pregnant women with twins have the opportunity for breastfeeding. The best thing is in an age of gestation more than 36 weeks. And that is the aim, to improve our management during the pregnancy. Thank you very much for your attention, and a little bit sorry for my English, but I hope the images and the slides are good enough for giving my ideas to you. Thank you very much.
Thank you very much, Professor Pahlmann. Believe me, your English is far better than my German, so I think that was very clear. Thank you, and thank you for really excellent overview and sharing your experience with us, and very clear messages at the end. It's my real pleasure to introduce the next speaker, Professor Monique Hack, who really doesn't need any introduction. She's very well known in this field. She's the head of the obstetric ultrasound department, and she's also a fetal therapist. So she deals with a lot of complex cases. She works at the Leiden, University of Leiden Center, which is the main center for fetal therapy in the Netherlands. She will talk to us on ultrasound imaging of twin-to-twin transfusion syndrome and TAPS, or twin anemia polycythemia sequence, and their management. So thank you, Monique.
Thank you, Asma, for your kind introduction. I will focus my lecture on showing a lot of ultrasound imaging and mainly focus on the ultrasound diagnosis. Because as Frans already said, if you detect these complications in monochorionic twins early, that really improves the outcome of the pregnancy. I want to sum up the most important complications, and Frans already focused on the complications in early pregnancy. So I will focus on the main complications in second and third trimester, which are TTTS, which is present in around 10 to 15% of all monochorionic twins, TAPS, and you have two types of TAPS. One is post-laser TAPS, that's up to 10%, but also a little bit depending on the center and on the reports that are written. In my center, it's luckily, I'm happy that it's quite much lower, but there are publications that state around 16 to 90% even. And secondly, spontaneous TAPS, so TAPS not after a laser, and I will explain to you that later. And although the title of my lecture did not mention growth restriction, I won't go too deep into that, but I will address the difference, the ultrasound difference between selective fetal growth restriction and TTTS. And look at this baby. This is a monochorionic twin during laser surgery. So this is the scope of the laser, and the baby is helping the fetal surgeon to direct the surgeon to the right spot to be occluded by the laser light. Very nice 3D image of one of my PhD students, Manon Geitenbeek. The cause of these complications are in the placenta. Here you see an umbilical cord. Here is the other umbilical cord. And this is a placenta of an uncomplicated monochorionic twin. And as you can clearly see, there are several connections between the two. We filled the vessels of this placenta with dye. And if you follow the color of the dye, you can see where the connections are. Typically, arteries are crossing over the veins. So the most superficial vessel is an artery. So blue is the artery here, and green is the artery there. And then you see here the first connection from left to right. It is an arterial venous connection. So the baby at the left side is giving blood to the baby at the right side. Here in the middle, and you see it also that the color is really going, the green color is really going to the left, but was infused here. This is a superficial artery-artery connection. And this connection can serve as can serve in two directions. So if the blood pressure is lower here, it will shunt in that direction. If the blood pressure is lower at the left side, it will shunt to the left side. Other type of connections are artery-venous connections, the other way around. And what, and I forget one, that is a venous-venous connection. This placenta has all connections. That is not always the case. So this is a venous-venous connection. An atrial connection typically protects against TTTS, because, as I said earlier, low blood pressure at one side, then it goes at that side, so it serves as a balancing connection. And the equator, we call this vascular equator, is more or less drawn by this line. But as being said, this is a 36 weeks placenta, uncomplicated, mainly, I think, because of the big AA connection here. Now we go to TTTS and TAPS. Twin-to-twin transfusion is caused by connections at the placenta surface which are not in balance. So the donor gives blood to the recipient. The donor is hypovolemic, causing less urine production, so a lack of amniotic fluid and a small bladder. The recipient is getting all that blood and is getting hypervolemic, so more volume in the circulating system. The fetus will increase the urine production, which causes an increase in amniotic fluid and a large bladder size. Now you can find this all, for instance, on the internet or in the original publication by Quintero. There are 5 stages, and laser is truly beneficial, proven in a randomized controlled trial from Quintero stage 2 onwards. Quintero stage 2, and deepest vertical pocket above 8 and lower than 2 centimeters, and above 20 weeks gestational age, 10 centimeters for the recipient. And if the babies are very small, before 16 weeks, I tend to make the 8 call it TTTS if it is larger than 6 centimeters. What is important in the staging system, that if there is no bladder visible, but the deepest vertical pocket is not yet reached, then it's not TTTS. You have to think if it's not something else. So it is subsequent. How does that look like? And I will show you a lot of ultrasound pictures in this lecture, because I really do believe that seeing those abnormal images will make you recognize it easier if you encounter such twins. Here you see a very large deepest vertical pocket. I think it's around 12. In here it is 10. And you should not, actually, if it is TTTS, you should not measure it in between legs or arms. You really see a big, deepest pocket with one fetus, maybe a bit at the side, but you should produce images. You should be able to produce images like this. This is almost 14 centimeters. And look at the placenta, how thin this placenta is. That is really a very, very important hallmark, a thin placenta, and also very important for the fetal surgery to be able to coagulate the vessels. Here is an example of a donor, and you see the intertwin membrane not really relaxated, but a little bit under pressure, but still this donor has more than 2 centimeters fluid. This baby doesn't. Here you see the membranes and the amniotic fluid, which is very small, less than 1 centimeter. And what is also very obvious visible is that the amniotic fluid is a little bit more dense here. And then to make it a little bit more difficult, sometimes you cannot find the membrane. And I will show you that in the next slide. Look at this donor. This was totally in the fundal area, so that is why this placenta is a little bit thicker, but it was really a TTTS with a little bit lower in the womb, a pocket of 10. And look at those babies, at those legs. The baby can still move the legs, so don't misinterpret this. and you have to look for the membranes very closely at those legs. So if a baby is moving in the amniotic sac, in this situation, in the amniotic sac of the recipient, don't think that it is a monoamniotic. This is a diamniotic baby in cocoon. We call that cocoon sign. I think a very beautiful example of cocooning. Here another example. This is also a pregnancy in early gestational age, 17 weeks. And here the hands are lying at the placenta, and look at where the amniotic amniotic membrane is. Arms and legs are really a good place to look for the membrane. So this is not monoamniotic, this is diamniotic with a stuck twin. Here another example. This is a sweep of a twin attached to the ceiling, as I always call it. Here the thorax, the heart, and what is also very contributing to the diagnosis is that you see the cord always very close to the fetus. So the cord is here around the belly. You see it here around the belly of the baby, around the abdomen, and it's never loose in the space of the womb. Cocoon sign of a donor. And what is furthermore very well visible is that there is no bladder filling of this donor. So if we resume tips and pitfalls, and then especially according to amniotic fluid discordance, really differentiate between TTTS and monoamniotic twins, because still I get some referrals. Is this a monoamniotic? And you diagnose a TTTS in a rather late stage. So is one fetus close to the uterine wall? Please think of TTTS. Is the umbilical cord in whole your examination very close to the fetus or around the fetus? Again, think of TTTS. This is cocoon sign. Important to look for the membranes around the arms and the legs, and furthermore, very important, look at the placenta, the appearance of the placenta. Is this flat? Then it is TTTS. Difference between TTTS and growth restriction of one fetus. If there is a differences in fetal biometry and there is an oligohydramnios or even an absent bladder of one fetus, but the other one only has a deepest vertical pocket of 6 or 7 centimeters, then it's probably growth restriction instead of TTTS. And again, secondly, if the placenta is not flat, also think of that it may be a fetal growth restriction. And if you are in doubt, please refer to a center for fetal surgery. Then another pitfall is cord insertion. As I already showed that placenta, and if I will show you more placentas, then you see that in TTTS especially, the cord insertion of one of the twins is quite often filamentous. So you see it here. Here is the recipient. Here is the cord insertion, and here, very close to the bladder, here you see the filamentous, the chorionic vessels at the membranes towards the placenta, which is here. So this woman really needs transvaginal examination to rule out vasa previa. Then the bladder sizes. Here are some examples of bladders of recipients. Recipients really do have big bladders. Donors is more difficult. Sometimes still a bladder present, but you can, as you can see here, this is a baby which is really a stuck twin. The umbilical cord is very close to the fetus, and this is the membrane. So this baby is a stuck twin, but still with some bladder filling. If TTTS progresses, then absent bladder, and you really need color Doppler to be sure that you are at the good side. This is a more difficult one. Again, you see lots of amniotic fluid of the recipient. This is, again, you see here the intertwin membrane, a baby, a donor, which is cocooning, and you may be in doubt, is this bladder filling or is it not? And yes, it is. If you put the color Doppler on, the color Doppler is around this bladder, but this is Quintero 2. As the ultrasound machines get so bloody good at this time, you see sometimes a very small, very small bladder, which does not fill. And if you're doing all your Dopplers and all the examination that you have to do at the first referral of this patient, then you have some time and you have to look several times during the examination if it is, and if it is so small and it does not fill, then there is no urine production. And in our center, we call this Quintero 2. Dopplers, I think because of lack of time, I won't go too deep into measuring the umbilical artery, because I think that is very basic. I think the audience will know how to do that. The ductus venosus is more difficult. Really look at the good spot. This is a normal ductus up to, let's say, 24 weeks. Then this, I would say, is very normal. And this one is of a recipient which is getting abnormal. The A wave is rather low. And what you also can see is that the early diastolic filling is not that high. So this is a babe. This is a really an ductus venosus of a hypervolemic fetus. And if babies deteriorate more, then you see that also the velocity, the highest velocity is dropping, and you see a reversed A wave. These kind of flows you can see in both recipients as in donors. And if they are like this, you really call this Quintero stage 3. If the Dopplers are looking as that last picture I showed you, you can also see this kind of contractility of the fetal heart with tricuspid insufficiency. This is a fetus of only 16.5 weeks old, and no hydrops yet, but really a poor contractility of the fetal heart. And I will show you another example again of a fetus in a very early gestation. And even in this case, you can see insufficiency of both AV valves. Really poor condition of the baby, enlarged heart. And here you see another phenomenon, which is called functional pulmonary atresia. This means that there is no really forward flow going across the pulmonary artery. You see here, and also the velocities you should put your color Doppler quite low because it's early gestation, and you can see here that there's red and blue across this valve. What is really important is that although these babies really do have a higher risk of fetal demise after the laser, that is really increased, these babies can get better if the laser has been done. So in my opinion, all these 3 cases that I show you had a good outcome, survived the laser and had no heart defects after birth. So my message is you should not be too pessimistic. These fetuses can recover, so you should not decide too easily to offer cord occlusion. I have written a paper about this, especially the pulmonary insufficiency these circulations always get better if they do not demise around the laser surgery. But there is a possibility to get right ventricular outflow tract obstruction, but mostly these fetuses show pulmonary stenosis, so increased velocities across the pulmonary artery. And I look at my watch and I see that I have to hurry a bit. I won't go in too deep into the treatment of TTTS because that cannot be covered in 20 minutes. But I think you all do know that laser is the best therapy to treat Quintero stage 2 and higher. Amnion reduction you can do, especially in late gestations and Quintero stage 1 situations, or in situations which are technically impossible. But if that are very early cases, I would I think I would advise cord coagulation if it is possible within the constraints of the law. And some people, because of all the complication rates, risk of premature birth, do choose from therapy and sometimes choose for termination, but that in my center does not happen often. And this is how a placenta looks like after a successful laser surgery after birth. Then only 2 slides to show you a case with selective fetal growth restriction, to point out the thickened placenta. This is not such a flat, thin placenta, but the donor, now I cannot call it donor, the small fetus, that ultrasound image really resembles the donor of a TTTS. But this is the key to the right diagnosis. This is selective fetal growth restriction. And what you also can do in these kind of cases is to use your SMI, which is a very good Doppler mode to depict very low velocities. And then you can see here, which is often present in selective fetal growth restriction, a big arterial. Here's the first cord. Then you see here the arterial connection. And at this side, you see the other cord. So a very good depiction of what the problem is in this twin pregnancy. And you can see that the placenta is quite thick. So this is not TTTS. And if you put your sample volume in such an arterial connection, you can see that the heartbeats of the 2 fetuses are really going against each other, producing the typical Gattenkos-tree flows. Then the second subject, which is twin anemia polycythemia sequence, really the Leiden disease, as some people call it. What differs from TTTS is that they normally have normal amniotic fluid and normal bladder sizes. So it's far more difficult to detect TAPS. The donor in a lot of instances can be small and may have an oligohydramnion. But the most essential part of diagnosis is the Doppler of the middle cerebral artery. What is the big difference is that there are not a lot of connections, but one or two very tiny, mostly one connection. And then this fetus has really a normal volume, but a low red blood cell count. And the TAPS recipient has again a normal volume, but a high red blood cell count. Now a picture of a middle cerebral artery. What is important to get a good signal is to be close at the circle of Willis, to have a small insonation angle, and because you use the peak systolic velocity, you should put in the angle. And furthermore, within one examination, measure it several times, take the best technical measurement that you have, And what is also very important, in the absence of fetal movements, because if the baby moves, then it will be increased, and the normal values are being made in the absence of movement. This is an example of MCA measurements after a laser. And then you see here that in the follow-up examinations that there is a big delta between the two babies. At this time, secondary signs of TAPS, which I will show you in the next slide, were visible. And that is this loop. What are the secondary signs of TAPS? And I think this is a very nice look and a very nice example. Here you see the TAPS donor, which has a whitish thickened placenta. So this placenta is hydropic. This is the TAPS recipient placenta, also with some white spots. And now have a look at the liver of this fetus. You see it here. This liver is very, very lots of white dots, which we call starry sky liver. I will show you one more time here, starry sky liver. The donor in TAPS, as always in fetal anemia, has an enlarged heart, but that is not always that obvious. And here again, a still image of a less severe example of starry sky liver with white dots within the liver. Oh, sorry. This baby, these parents were enrolled in our TAPS trial and were randomized for intrauterine blood transfusion and exchange transfusion. This is thinning of the blood with saline. And there were 3 transfusions done. And you can see that the red blood count levels were quite low. So at this was the time of the randomization, and these were the intrauterine transfusions. So that was done weekly, and these twins were delivered at 30 weeks with a good outcome. And here is an example of the intrauterine fetus in the umbilical vein. If you look closely, and if the resolution of your screen is high enough in the transfer of those thousands of kilometers, you can see here the blood going in to the umbilical vein. Good outcome for these twins, and you can see here that the laser line was not complete with here, and this is an enlarged part. Here, a very, very tiny vessel causing the TAPS. This is a second example. These were measurements in the referring center. Here, the randomization. Here, after that, at the arrow, the laser was done. This case was randomized for laser, and then you see here the birth of healthy twins at 35 weeks. So also a very good outcome. The RCT is ongoing. And why are we doing an RCT? It is easy to think that laser is the best possible treatment. That can be obvious because you treat the underlying problem. But the laser, in these cases, it can be technically very, very challenging because the polyhydramnios and the flat placenta are mostly absent. The oligohydramnios is not often so severe, and laser always carries a risk of labor, rupture of membranes, and losing the whole pregnancy. IOT has probably a far more lower risk of the procedure, but has to be repeated several times. In our experience, you cannot do that more than 3-4 times. So if your TAPS is here, then you come really in very early, very extreme prematurity. So this is the example of spontaneous TAPS. Here there are no, this is not a laser line. Here are no connections. And if you enlarge this part, then this is the tiny connection which is causing the TAPS. And always turn around the placenta of TAPS, because then you can see this pale and dark. When does, and this is my final slide, when does spontaneous TAPS occur? And you can see these are absolute numbers, and you can see that it can occur. And of course, there is some diagnostic delay in some cases, so it's not so absolute. But if we look back at our referrals, you see that it is a problem of all trimesters opposing to TDTS, which not so often occurs after 28 weeks. So my take-home message is that the outcome of TDTS laser is quite good. So please diagnose early. Try to diagnose as early as possible. Membranes, bladder, amniotic fluid, and also the placenta thickness are cornerstones for diagnosis. Don't think it is a monoamniotic pregnancy. Really look carefully for the membrane and make a distinguishing between growth restriction and TDTS. I thank you very much for your attention, and I especially want to thank the people of my team, the ultrasonographers and PhD students that helped me in getting these pictures, and of course the rest of my team and my fellow field surgeons. Thank you very much.
That's brilliant. Thank you so much, Monique, and thank you for sharing your experience and for being very practical and really giving practical tips. So I really enjoyed your talk. So great. Thank you so much, Monique. I'm going to actually do my talk, which is about guideline on routine monitoring. We are a little bit behind, but to some extent, I think it doesn't matter because I think we are enjoying it and we're learning. So I'm really grateful to the speakers for sharing their experience with us. There might be some overlap in my talk with sort of the previous two talks, but I think that's okay because we're talking about the guidelines and repetition is not a bad thing. So how should we determine gestational age in twins? And already Frank mentioned that in his talk. So in spontaneously conceived twin pregnancies, you would use the larger twin. We tend to date the pregnancy when the crown rump length measures between 45 and 84 millimeter. What about in IVF pregnancies? In this case, we use the oocyte retrieval date or the embryonic age from fertilization. How to determine the chronicity, and it's probably the most important thing from the entire webinar, is how to determine the chronicity, because that determines the risk in the pregnancy and also the management for the rest and the monitoring. So it's really simple. Ideally, we should do it early in pregnancy, so in the first trimester, so before 14 weeks. And you can use a number of ultrasound features, as you can see here. So you're looking at the thickness of the membrane. Let me just get the point. Yeah, so the thickness of the membrane at the site of insertion of the membrane into the placenta or the intertwin membrane in the placenta. And if it's thick, as you could see it earlier in the here in the videos, so that's the lambda sign, that's a dichorionic twin. If it's thin, that's the T sign, and that's monochorionic twin pregnancy. You could also use a number of placenta masses if you have anterior placenta and posterior placenta, so that's dichorionic. And certainly when we wrote the ISWAC guidelines, we did recommend that you should have an ultrasound image demonstrating the chronicity in the patient record for future reference in case patient moves from one center to another or moves from one country to another. But be careful, because in dichorionic twin pregnancies, is often the two placentas are next to each other, so they look like one placental mass. And also in about 3% of monochorionic placentas, you can actually have two placental masses on ultrasound scan. So just number of placental masses is not very reliable. Okay, what about if actually the patient present after 14 weeks, so you miss this golden opportunity in the first trimester? In this case, you still can use some of the features. Sometimes the thickness of the intertwin membrane is clear, it's quite thick. Sometimes the placenta, number of placental masses, anterior and posterior, and scored and fetal gender. So if it's a baby boy, baby girl, that's likely to be dichorionic twin pregnancy. What about if it's difficult? So you can't determine the chronicity. For example, the views transabdominally are poor. In this case, you or the woman have retroverted uterus or high BMI. In this case, you need to do transvaginal ultrasound scan. Okay, what about if it's still not possible? In this case, you should get second opinion from a senior sonographer or a fetal medicine specialist. What about if it's still difficult? Of the first time you see this woman is 28 weeks and the same gender and can't really, it's difficult to be certain. In this case, you should manage this pregnancy as a monochorionic twin pregnancy, because that means you will monitor closely. You will see the pregnancy every 2 weeks for ultrasound scan to looking for monochorionicity related complications. So that's about the chorionicity. What about the amnionicity? And amnionicity, you're looking for the intertwin membrane, so the absence of the intertwin membrane that indicates monoamniotic twin pregnancy. But be careful, because I see a lot of the cases where the referral is monoamniotic twin pregnancy, but actually when you do a transvaginal ultrasound scan, you see the intertwin membrane. Sometimes the membrane is very thin that you don't see it transabdominally. The other sign, which is also very reliable, is the cord entanglement, which again is almost pathognomonic of monoamniotic twin pregnancy. Again, is it 100%? No, because there are some pitfalls. So if you see, for example, this pregnancy or this ultrasound image, what you would say, well, you say, well, the thickness, the intertwin membrane at the site of the insertion to the placenta, well, it looks like a lambda sinus, it's a bit thick. But actually, if you would color Doppler, you see that there's a blood vessel running in this intertwin membrane. And you see here, this is the pathology, or this is the placenta and the pathology post after delivery. And in fact, this case report is published. And in fact, this pregnancy, I think, was complicated by selective fetal constriction. Why chorionicity is important? Because the risk of adverse outcomes tend to be higher in monochorionic compared to dichorionic pregnancies. And you can see that clearly from these figures. If you want more up-to-date figures that also include comparison with single-term pregnancies, whether the risk of miscarriage or perinatal death or fetal growth restriction or preterm birth, and also the risk in monoamniotic twin pregnancy. And I think this slide is really useful when you're actually doing the initial counseling. And the next really important thing is to label the twin pregnancies. How should we label them? Well, and again, ISWA guideline and the FIGO guideline, we did the recommendation is that you include as many features as possible when you describe each twin. So for example, you say twin 1 is a female on maternal right with posterior placenta and marginal cord insertion, while twin B is a male on maternal left with anterior placenta and central cord insertion. And that's really important, because the next person scan you, if it's a different professional, you need to make sure that there's no confusion. Of course, if there is a feature that differentiate them, so you have a discordance, so if you have a twin-to-twin transfusion syndrome, it's very easy. You have the recipient and you have a donor, or you have a selective fetal constriction, the larger twin and a smaller twin. If it's a monoamniotic twin pregnancy, it's difficult because they sometimes, particularly early in pregnancy, they can move from right to left. And I think you need to be aware of something called perinatal switch phenomena, which occurs in about 20% of the pregnancies that are delivered by cesarean section, even up to 6% in those who delivered by vaginal delivery, where actually twin 1 during ultrasound scan is born as twin 2. And why is that important? Well, I think it's really important if in a twin pregnancy where there is a discordant anomaly that's not obvious by external examination. So for example, if you have a twin pregnancy with one twin have congenital diaphragmatic hernia, and the other one is normal and the same gender, you need to be aware of that, and you need to communicate that to the neonatologist, and you need to have a peri-apartment plan, how you would differentiate or identify the twin that has the abnormality that needs an immediate management. You need intubation, for example, soon after birth. How do we monitor twins using ultrasound scan? And again, this is the flowchart that we included. We included in the ISWA guideline. It's also included in the FIGO guideline, and also is adopted in the NICE guideline. And in whether dichorionic twin pregnancy or monochorionic twin pregnancy, in the first trimester, so 11 to 14 weeks, you would do the dating, you would do the chorionicity and amnionicity, you do the labeling, and you offer screening for chromosomal abnormalities depending on where you practice. In a dichorionic twin pregnancy, the next scan is a 20-week anomaly scan, we do the biometry and anatomy, look at amniotic fluid volume and measure cervical length to screen for preterm birth. And then after that, you scan every 4 weeks until the end of the pregnancy because you're monitoring for fetal growth restriction. At every scan, we need to calculate the estimated fetal weight. And that's really important because that helps you to identify selective fetal growth restriction. And it's easy to calculate the estimated fetal weight discordance, estimated fetal weight of the larger twin minus the smaller twin divided by the larger twin, and you multiply by 100 to get the percentage. What about in monochorionic twin pregnancies? Completely different story. So after the first trimester, you need to do ultrasound scan from 16 weeks, every 2 weeks until the end of the pregnancy, because you're looking for twin-to-twin transfusion syndrome, as well as, of course, as well as fetal growth restriction. So every scan, you need to measure the two babies, the biometry, you calculate the estimated fetal weight discordance, you measure the deepest vertical pocket, like what Monique showed us. And you also, we recommended in the ISWAC guideline is that we start doing the Dopplers, umbilical artery Doppler, and particularly the middle cerebral artery big cerebral velocity, because we're looking for TAPS or twin anemia polycythemia sequence from 20 weeks. So again, I have this slide, this is for monochorionic twin pregnancy, first trimester, and then from 16 weeks, every 2 weeks until the end of the pregnancy. And this is ultrasound, this is a biometry, the deepest vertical pocket, how you measure it, and this is the Doppler. Regarding the abnormalities, how common are anomalies in twins, and do they differ according to chorionicity? Well, if you look at anomalies in twins, yes. So in dichorionic twin pregnancies, the risk per baby is the same as the risk in singleton. So singleton, the risk of anomalies is about 2%, but in dichorionic twins, you have 2 babies, and therefore the risk is 4%, 2 by 2. Majority of the abnormalities tend to be discordant, 90%, and only 10% are concordant. So both twins are affected. In monochorionic twins, there is actually, the risk is higher of abnormalities. The risk is twice compared to singletons. And so that's 4% per fetus, and you have 2 babies, and therefore is 8%, and 80% of these abnormalities tend to be discordant. Why monochorionic twins have higher risk of abnormalities, or the number of series, but the commonest or the most popular is that the teratogenic effect of the embryonic split, this Christmas cracker theory. What's the detection rate of abnormalities in twins? And we published this paper a few years ago, and we reported that the detection is about just under 30%. So under a third of abnormalities are diagnosed in twins in the first trimester. And we also shown with the data that the risk factors monochorionicity, as I mentioned, they have high risk of abnormalities, but also discordance in the crown rump length or the nuchal translucency. And this is exactly the same results from more recent data from King's College, where the detection rate in dichorionic twins 27%, almost the same. In monochorionic twin, 50%, but because also they included trap and conjoined twins, which we haven't. We just looked at the structural abnormalities. What about screening for chromosomal abnormalities? So clearly the combined test, which is a detection rate of about 85% for about 5% false positive rate, whether it's dichorionic or monochorionic twins. What about the cell-free DNA? Well, cell-free DNA is the most accurate screening test for trisomy 21, 18, or 13 in singleton pregnancies. You can see 99% for a less than 0.05% false positive rate. What about in twins? Now, when we wrote the guidelines, or you read the guidelines, we found that the guidelines would say, well, this cell-free DNA looks very promising, but we need more data in twins because the data in twins is less than data in singleton. And in fact, the American College of Obstetrics and Gynecologists, or the SMF, when they published their guidelines, the most recent guidance on screening for fetal chromosomal abnormalities, they did actually recommend cell-free DNA in twin pregnancies, so it can be performed. If you look at the data, it seems in twin, for trisomy 21, very good, so more than 95% detection rate for less than 0.1% false positive rate. For trisomy 18 and 13, it seems to be less. So when you do ultrasound scan first trimester, what is the significance of size discordance in the first trimester? Well, it depends how early at what gestation in the first trimester. So if you do it really early, so at 7 to 10 weeks, and that you find discordance in the size, that's not good news because it is predictive of single fetal demise in the first trimester. So it's likely there's a high chance when this woman comes back for her routine first trimester scan between 11 and 13 weeks that the smaller embryo, the smaller baby, might have already demised or had a miscarriage. The optimum cutoff, about 20% discordance in the crown rump length. The detection rate is nearly 90% for a 5% false positive rate. That's not necessarily the case at the 11 to 13 weeks, where the discordance in the crown rump length or the nuchal is not necessarily associated or predictive of the risk of miscarriage or fetal demise, but is associated more with the risk of fetal abnormalities or aneuploidy. If you look at the risk of fetal abnormalities, if you have a discordance less than 10%, risk is 4%, while actually discordance length of 10% or more is much higher, 25%. And therefore, the guidance is that if you have a discordance in the crown rump length of more than 10%, or in nuchal translucency, you need to do the detailed anomaly scan, consider offering invasive testing for genetic testing, or refer to fetal medicine specialist. If you need to do invasive prenatal diagnosis in twins, when we wrote the guidelines, we did recommend that CVS is the preferred option in dichroic twins because it allows you to have first trimester diagnosis. And that means if there is an abnormality and the parents wish to have selective termination, you can offer them a safer first trimester selective termination associated with a lower risk of miscarriage and preterm birth. For monochorionic twin pregnancy, it's a different story. If you have a discordant anomaly, it's better to do double amniocentesis. What is the risk of miscarriage or fetal loss in doing CVS in twin pregnancies? The risk is about 2%, but when we wrote this, we published this meta-analysis, the risk is 2% for those who twin pregnancies undergoing CVS, but also is about 2% in those not undergoing CVS, and therefore in this analysis, the risk was not significantly higher. There's some more recent data that maybe shows something different, but certainly the data differ, or the analysis actually have controversial results. How do you do it? How do you do the CVS in a dichorionic twin pregnancy? You've got the two placentas, they're next to each other. And therefore, again, according to ISWA guideline, we need to try to sample near the cord insertion from each side and try to avoid this area where there is attachment to the intertwin membrane to avoid contamination. Or alternatively, if it's not accessible, you can do one CVS transabdominal and the other CVS transcervical. And it's important to mention in your consent or your counseling that there is a small chance of cross-contamination, about 1% of CVS in twins. And again, the sampling error or inaccurate sampling, again, about 3 to 4% of cases. And therefore, you need to be very, very careful. And also do mapping at the time of doing the invasive testing in case you need to go back and do selective termination. In a monochorionic twins, it depends. If they are concordance, you can do just a CVS and you can target the area where there is attachment to the intertwin membrane. But particularly if there's a discordant anomaly in a monochorionic twin pregnancy, it's better that you do double amniocentesis to avoid missing heterokaryotype or different genetic makeup in the twins. How do you manage cases of twin pregnancies with discordant anomaly? They tend to be really quite complex, and therefore, if you don't have necessarily a lot of experience, it's better to refer them to a fetal medicine specialist, because the management and the counseling of these cases tend to be a little bit complex. Take into account the nature of the fetal abnormality. Is it lethal or is not lethal? And if it's lethal, is it likely to be lethal during the pregnancy or afterwards? If it is afterwards, you can do expectant management, but if it is lethal or likely to be lethal during the pregnancy, in this case, in a monochorionic twin pregnancy, where if the abnormal twin dies, there is about 30 to 40% risk of demise or neurological damage to the surviving or the co-twin, the normal twin. In this case, you might actually be more proactive and to consider offering selective termination. Also, the management of chorionicity is different. So I think there are a number of things that you need to take into account. What's the best? What about screening for preterm births? There are a number of potential markers for screening for preterm births, but certainly in twin pregnancies, the most accurate is the cervical length, and the cutoff is 25 millimeter. And when should I measure the cervical length to screen for preterm births and twins? Is at 20 to 24 weeks. What about fetal growth restriction? I mentioned it earlier. When you do the monitoring, you need to measure the biometry, calculate the estimated fetal weight discordance. So how do you measure, how do you define what are the diagnostic criteria of selective fetal growth restriction? When we wrote the ASWA guideline, it was a consensus of a group of experts around the table in the ASWA office in London. And we felt that, well, in diachronate twins, we can manage it as singletons if it's one twin with estimated fetal weight less than 10 centile. But for monochronically twins, where a lot of them are small, in this case, not just one twin with estimated fetal weight less than 10 centile, you also need to include estimated fetal weight discordance of 25% or more. But when we, after the publication of the ASWA guideline, which was published a few years ago and is currently undergoing update, we received a number of letters because highlighting that actually the diagnostic criteria of selective fetal growth restriction in twins are different, and they're different in different papers. And therefore, we published this Delphi consensus for diagnostic criteria of selective fetal restriction. And this is currently most of the papers that are currently being published or sent for review are using this diagnostic criteria. So if you have one twin with estimated fetal weight less than 3rd centile, that's enough to diagnose selective fetal growth restriction in twin pregnancy, whether diachronic or monochorionic. But if you want to use a conventional cutoff of less than 10 centile, in this case, you need to use, in addition to that, you need to use discordance of 25% or more, or abnormal umbilical artery Doppler. And you already sort of have seen lots of really very nice ultrasound images by Monique, but this is a selective fetal growth restriction in a monochorionic twin pregnancy. And as she pointed out, you see this huge size discordance, but the key thing, and often the smaller baby have oligohydramnias, the key thing to differentiate from twin to twin transfusion syndrome is the absence of the polyhydramnias around the larger twin. The twin pregnancies, particularly the one that are complicated by selective fetal restriction or TGTS, they have risk of demise of one twin. So how do you actually counsel a twin pregnancy that's complicated by single intrauterine demise? This slide is really useful to give you the idea about what you need to discuss and some figures to counsel the patients. You need to discuss 4 risks. What is the risk of demise or death of the surviving co-twin? What's the risk of preterm birth? What is the risk of brain abnormalities in the surviving twin? What is the risk of neurological abnormalities? And you can see clearly from these figures that the risk is significantly higher in monochorionic twins compared to diachronate twin pregnancies, except in the risk of preterm births, which tend to be high both in diachronic and monochorionic twin pregnancies, particularly if the demise occurs in the second half of the pregnancy or in the latter or in the 3rd trimester. This flow chart is just a proposal how you manage a single intrauterine demise in a monochorionic twin pregnancy, where absolutely the key is to be referred to fetal medicine specialists to do detailed ultrasound scan, try to figure out the cause of the death of this twin, and then do the Dopplers, particularly the middle cerebral artery systolic velocity, because you're looking for anemia in the surviving twin. And if there is anemia and the demise occurred recent, in this case, you might need to do urgent intrauterine transfusion. In this case, after that, you still need to continue monitoring this pregnancy every 2 weeks by biometry and Doppler, and offer MRI, not at the time of the diagnosis of the demise, but 4 to 6 weeks later, because you're looking for brain abnormalities. And in terms of the delivery, again, we tend to deliver at 34 to 36 weeks because of the residual risk. TTS, already we heard from Monique, it's because of the unbalanced blood flow across the vascular anastomosis. The key features is polyhydramnias and oligohydramnias, and often there is also evidence of cardiac compromise, particularly in a recipient twin. In terms of the diagnostic criteria or the staging, I think already Monique has gone through that, so I'm not going to repeat it. But what I'm going to highlight is the recent evidence, what has been published recently. So she told you about the Quintero staging, 5 stages. The one, you still see the bladder in the donor. The stage 2, when you don't see the bladder anymore in the donor twin. Well, actually, once you have abnormal Dopplers, you that's a stage 3 already. And if you have hydrops of one or both twins, that's a stage 4. And if you have demise of one twin, that's already stage 5. What's the new proposal is the fact that you combine stage 1 and 2 together and stage 3 and 4 together. And this is this data from the German group from Kurt Hecker. And why is that? Because if you look at the risk of double survivor, or at least one survival, you find that the stage 1 and stage 2, they're similar, about 70% double survival and 90% at least one survival. While if you look at the stage 3 and 4 together, you see it's about 55% or 50% double survival and about 70 to 80% at least one survival. And therefore, you combine the stage 1 and stage 2 together, stage 3 and stage 4 together, and you simplify it and you have just 2 stages for TTTS. If you have normal Doppler, that's one stage. If you have abnormal Doppler, that's the second stage. And the reason is because there doesn't seem there is value in differentiating stage 1 and 2 from each other and stage 3 and 4 from each other in terms of survival. In terms of the treatment, we know that the TTTS is the first line treatment in cases of TTTS for stage 2 or higher. What about stage 1 TTTS? We know that the stage 1 TTTS trial, which showed that there is no benefit in offering laser for stage 1 TTTS in asymptomatic cases with a long cervix. Finally, what about TAPS, or twin anemia polycythemia sequence? And again, we heard already from Monique, it's because of this tiny anastomosis in the placenta, allowing the flow from the red cells, but there's no fluid discordance. It's mainly discordance in the red cells, and therefore you have anemia in one twin and polycythemia in second twin. And most cases occur after the laser surgery for TTTS, but there are some cases that can occur also spontaneously. The diagnostic criteria is the donor have peak systolic velocity above 1.5 mom, while the recipient have peak systolic velocity less than 1 mom. That was the traditional diagnostic criteria. And the most recent diagnostic criteria, which is the Delphi, you have the donor of peak systolic velocity of 1.5 mom or higher, so the same as the old criteria. But for the recipient, you have a lower cutoff of 0.8 mom rather than the 1 mom, but also including the discordance in the peak systolic velocity of 1 mom or higher. So it's a little bit more complicated. Management options, it depends. We don't have a strong evidence from randomized control trial. There is a trial that's ongoing, but certainly the management options is expectant, particularly in mild cases, preterm births, particularly after 32 weeks. You can give steroids in the liver. Laser surgery, similar to what we do for twin-to-twin transfusion syndrome, but tends to be more difficult, or giving blood transfusions to the anemic twin and partial exchange transfusion for the polycythemic twin, or selective termination, particularly if you have a discordant anomaly. Should we screen for it, and can we prevent it? And in the ISWA guideline and the FIGO guideline, we did recommend that we should monitor for TTS by measuring the MCA peak systolic velocity in all monoclonal twin pregnancies, even the uncomplicated ones from 20 weeks, but definitely in all the follow-up cases after laser for TTTS. Can we prevent it? Yes, we have evidence from randomized control trial that if you do the Solomon during the laser, you reduce the risk of post-laser TAPS. The monitoring is controversial. Not all guidelines do recommend routine monitoring for TAPS, or twin anemia polycythemia sequence. I was a member of the NICE guideline update that was published in September 2019, and certainly in NICE they don't, and the American guideline also do not recommend routine monitoring for TAPS because of the lack of evidence on what's effective or the best treatment. But certainly the NICE guideline, we did recommend that we should be doing MCA peak systolic velocity weekly from 16 weeks for all cases of complicated monoclonal twins and the one that had treatment, or the one that had laser treatment for TTTS. So whether you have TTTS, selective vasoconstriction, abnormal Doppler, hydrops, unexplained, all of these cases, you should do the MCA peak systolic velocity from 16 weeks weekly. Finally, when should we deliver twins or uncomplicated twins? And we published this paper in the BMJ a few years ago, more than nearly 26,000 twin pregnancies. And we do this analysis of balancing the risk of stillbirth versus the risk of neonatal death. When these two lines cross, this is the cutoff at which the risk of stillbirth is exceeds the risk of neonatal death, and therefore this is the cutoff that you would recommend delivery. And in monochorionic twins with 36 weeks, in dichorionic twins with 37 weeks, and this is a cutoff that we should recommend delivery of uncomplicated twin pregnancies. And this was a NICE guideline: dichorionic twins 37 weeks, monochorionic diamniotic twins 36 weeks, monoamniotic twins 32 weeks. From 32 weeks after a course of steroids. And I didn't really stop because of the time. I didn't show you the data to support that, but it's a similar analysis. For twin pregnancies that do not want to have elective delivery, in this case, you need to monitor them by ultrasound scan, doing weekly assessment of the amniotic fluid volume and umbilical artery Doppler. Does it matter? Is doing ultrasound monitoring improve the outcome of twin pregnancies? And the answer is yes. This is our data. And this is the risk of stillbirths in twins. And this is when we implemented the NICE guidelines and the ISWG guideline. And this is the stillbirths post-implementation, pre-implementation, significantly lower. So we managed to reduce the risk of stillbirths in twins after the implementation of the guidelines. And therefore, yes, it matters to do follow routine monitoring and follow the guidelines in twin pregnancies. And we noticed that the reduction in stillbirth was more in monochorionic twin pregnancies, about more than 70% reduction in stillbirth in twin pregnancies, particularly monochorionic twin pregnancies, without increase in other adverse outcomes with a neonatal death, admission to the neonatal unit, or emergency cesarean section. So I'm going to stop here and thank you very much for your attention. So I'm going to like to invite the other speakers to join the discussion. I have a question to Frank. So for the first trimester ultrasound, you mentioned about the discordance in the crown rump lens, or the discordance in nuchal that is associated with adverse outcomes. But we also know that they are not very good predictors. So in your own practice, if you have a discordance in the crown rump lens, how would you counsel the patient? And how would you monitor this pregnancy? Would it be different to a twin pregnancy where there is no discordance in the first trimester?
I think we should be very careful. And at first thing, I would like to wait. The next we see a discordance of around about 12, 13 weeks. And my practice guide is that I would like to check it in 2 weeks again, and make no stress for the patients. And then we can decide what to do, because in this early age of gestation, we have a lot of time. And so it could be that there was a natural demise. And if there was if the pregnancy is going on, and we see also that there was an increase in discordance, then we have to discuss it with the patient. If we in dichorionic make sampling for the chromosomal abnormalities, we should also check it with defects to rule out this. And but I think we have time for 2-3 weeks or 4 weeks, and we should take this time, because there was no, to my mind, no idea of intervention. So it's better than we check it in 2-3 weeks later. Okay,
fantastic. Great, thank you very much. We have many questions, and I am conscious of the time, so I'm going to ask some questions specific to a specific speaker with maybe short answers. So again, a question to Frank. If we have from South Africa, if one twin demise at 8 weeks, would it be absorbed? So a common thing that you see on the internet, or the patient said, well, I've been told that, you know, if one baby dies, the doctor told me that the other one, just my body absorb it. Is that correct?
Yeah, it's not so easy, but in the most case, it will be absorbed. But some histological examination showed that there was an small tissue after this examination, so we can check it and we can see it all after placental examination. But by ultrasound in 8 weeks, we check it at 20 weeks, we couldn't see this small fetus. But in histological examination, it's possible that we check it, yeah, and see it also.
That's great. Thank you very much. Monique, there's a question for you. If you're going to do cord occlusion, which twin do you choose, the donor or the recipient?
Now, you don't do so often cord occlusion in a fully only TTS case, because in my center we almost always are capable of performing laser surgery. So the indications are, the reason to do so are probably because of abnormalities. And then, of course, you choose the fetus which is abnormal. Another reason could be growth discordance, but then it is not because of TTS, but because of selective fetal growth restriction. So then you choose the small one. And if you do it solely for TTS, which in my experience, I believe I never did, I would choose, if it really is technical impossible, you would choose for the recipient, because you have better access to the umbilical cord. And if you look at long-term outcome of TTS fetuses, recipients sometimes have heart problems, like right ventricular outflow tract obstruction. So I would choose for the recipient, but seldom the case. And especially if centers do a lot of cord occlusion for anterior placentas, I think it's not necessary. Let's put it in that words.
Okay, fine. I totally agree with you, Monique. Thank you very much. So Frank, you didn't mention the trap in your talk, which is very nice for you to include it. So this question for you: which method do you prefer to calculate the estimated fetal weight of trap, and what are the criteria for intervention in trap? So the cutoff. So we know, for example, there's one. Certainly, if there is a large, the trap mass is large in relation to the size of the normal twin, that sometimes can be an indication for intervention. So how do you calculate? What's the best method to calculate the estimated fetal weight of the trap mass, and what are the intervention criteria in your experience?
It could be. We have to check it very intensive to look what is pulsatility of the ductus venosus also, because then we see what is the hemodynamic condition of this pump twin. And so because if this was stable, and it's also depending from the gestational age, we can make also a conservative or an expected management. So, but the risk for this baby is higher of preterm birth and extremely preterm birth. If the baby is the trap fetus is too big, so the laser coagulation could be very difficult because the tissue is too much and the energy are too small. So we have also the options that we make an coagulation or with fetoscopic umbilical cord coagulation or make a node. And we have also some experience with histoacryl application by needle and give it directly in the cardiac, in the vessels. So there are some options that we can do, but it's an individually decision to make this. So it's not, it's a very severe and not so easy management in this case.
Yeah, I agree with you. And of course, there's another option, which is radiofrequency ablation. Do you have experience with that? And there's some data that's published on using microwave. Do you have any experience with that?
I haven't understand, I'm sorry.
Do you have any experience with radiofrequency ablation or microwave for treatment?
No.
Yeah, but I mean, certainly the radiofrequency ablation is, Yes. So Monique, do you want to maybe comment on
Yeah,
that?
we almost do every trap case with RFA and very good outcomes with that. And I think there are some publications which compare the both techniques. I think it's mainly what you are used to. It's really difficult to compare it. That would be a nice subject to do a multi-center with randomization between techniques to really answer that question, because literature will not give you the answer.
Yeah, that's right.
Yeah, and for microwave, I mean, I don't have experience with microwave, and I don't think actually Monique or Frank, I mean, certainly it's only a few case reports that's been published in the literature, so I don't think it's a commonly used or practiced in routine clinical practice. Okay, so there's loads of questions here. They're coming very quickly. How do you diagnose TAPS at 15 weeks, Monique?
No, I think 15 weeks is quite early for TAPS.
Have you ever seen a case of TAPS at 15 weeks?
No, I think that the earliest one in our center are around 18 weeks. And then you just wait a bit, because sometimes it develops into TTTS and you are not too aggressive, you wait a bit. And in a lot of cases, it's also a little bit intertwined, and it also looks like TTTS, so you should be very careful. And if it develops into TTTS, you can just do a laser. But it is possible just before 20 weeks, yes. We've seen that several times. And how to diagnose, just MCA Dopplers, easy. Just what we showed you in the lectures.
Yeah, and in the data when we had the TWIN registry, which is a large multi-center international TAPS registry, and we published about maybe 3 or 4 papers a couple of years ago, there were early cases of TAPS. In IVF, okay, there's another question. In IVF pregnancy, shouldn't we use the date of conception as provided in machine? Yes, so often if the patient have already expected date of delivery that's given by the IVF clinic, you can use that. Otherwise, you will need to use, when was the transfer. So just as you dating an IVF pregnancy. Next question on labeling twins. Is there a chance that twins can swap position in monochorionics should the twin A ever become twin B? We should not change the labeling. It can happen in monoamniotic twins where they can swap, but if you have monochorionic diamniotic twin pregnancy, we should not sort of swap the position unless sometimes you have a spontaneous septostomy or after laser, where maybe they have a shared sac, and therefore, yes, you can sort of twin 1 can become twin 2. But otherwise, usually we have consistent labeling, and we're extremely reluctant to change the labeling. Another question, why Doppler in every scan in dichorionic twins? Very good question. And that's not really necessarily supported by strong evidence. And in fact, the American guideline, the American College of Obstetrician Gynecologists, they don't routinely recommend routine assessment of Doppler in the absence of, for example, fetal constriction or discordance in size. As I mentioned, when we wrote the ESWA guideline and for FIGO as well, that was a consensus based on experts rather than based on strong evidence. But sometimes the lack of evidence does not mean that we shouldn't do it, particularly in twins, because the data tend to be limited and you don't have large studies, or you don't have sometimes a high quality evidence like what you have in singleton pregnancies. But yes, I agree with you. There is the difference. There is difference between the guideline. Thank you for the excellent talk. Could Prof. Khalil show again quickly the slide summarizing the risk of MCDA and MCNC counseling? Okay, definitely we can share that with you. So this is the recent figures, and we'll have the risk of singleton. You've got the risk in dichorionic twins, the risk in monochorionic twins, and also the risk in monoamniotic twin pregnancies. But also this recording of all this, the talks will be available. So you should be able to have access to all the content. Next question. Thank you. What's the best color Doppler criteria in uncomplicated TTS? I mean, in umbilical artery of the recipient. So in the Doppler abnormalities are not don't know, Monique, do you want to comment on that, on the Doppler abnormalities in GTS? And often you find different Doppler abnormalities in the recipient versus the donor. Monique, do you want to comment on that?
Yeah, I would advise not to be too black and white on that. It is not always the case that it is the recipient that shows the abnormal Dopplers. It can be the other way around. So I would, if I may give an advice, just start with the basics. Start with the bladders, the amniotic fluid. If that is all normal, and you have a normal arteria, umbilical artery, and a normal MCA, I would refrain from doing the very difficult duct and that kind of things. But if you are in doubt, yeah, you should refer, or you should add those other vessels to your investigation, and you should have a close look at the fetal heart.
Okay, fantastic. Look, we have so many questions and they keep coming, but I'm conscious of the time. You've got our contact details, so please feel free to contact us. I'm sure we would be delighted to answer the questions. But I'd like to thank the speakers, fantastic talks, and amazing to share the experience with us, and really fantastic engagement from the delegates. I love when you have so many questions. I wish we could carry on for another 2 hours to have more discussion and more sharing experience. But thank you very much. I really enjoyed it, and I hope that you enjoyed the rest of your evening or the rest of your day.
I'd like to say thank you very much on behalf of Canon Medical to our amazing speakers, Professor Asma Khalil, Professor Franz Ballmann, and Dr. Monique Haag for your really fabulous talks. And a special thank you to Professor Khalil for her great moderation and taking care of the question and answers. So thank you very much for joining. Wishing you all a relaxed evening, a good start in the day, and a good night. Bye-bye.